welcome everyone today. I'm really delighted to have Dr. Luca from Apricity. I'll let him introduce himself in a second. Talking all about those practical questions around treatment and the questions that we often have in our minds when we embark upon donor egg treatment. So I've collated some questions that you sent to me, and I'm just going to hand over to Luca just to introduce himself briefly before we jump straight in.
Oh, thank you very much, Becky. It's a pleasure to have met you today and to talk for the benefit of your listener, really. I'm a doctor. I've been working in this field for 25 years. I train as an embryologist, and also I've been a clinician. I've been a clinical director of a big IVF unit in London, and now recently joined Apricity as a chief medical officer. I also have a personal experience of fertility treatment, so this also has made me understanding a bit of 360-degree the field, really. And I'm delighted to be here to take your questions.
Thank you. No, it's amazing to have you. And I think there can be so much information out there. It can be so overwhelming at the very beginning. So to have somebody who's got that experience, but also understands how it feels to go through this process, I think is really important. But I'm going to get straight in and sort of go back to basics, really. So someone who may have just had the concept of donor eggs mentioned to them as an option for them to build their family, what might they expect from a typical donor egg protocol, IVF cycle, both for them as a recipient, but also on the other side, what's going on with the donor too?
Yes, that is a very interesting question, because I suppose we all think how difficult it will be, how time-consuming and physically demanding will be. Once that the donors has been selected and the recipient has been matched, then at that stage the medical aspect requires two main important points. One is to synchronize, so make the recipient uterus preparing at the same time while the donor also start producing eggs. These are normally dealt with by two different teams, two separate teams. There's a team looking after the recipient, which will aim at developing the endometrium in the best way as possible. We normally use medication as simple as tablets, and the tablets are made by the same hormones, which sometimes are in the contraceptive pill or in the hormone replacement tablet. This is estrogen, which is taken daily and aim at thickening and develop the endometrium, which is then followed by ultrasound normally. So a woman undergoing to the pathway of accepting an egg, so a recipient will have normally an ultrasound at the very beginning to assess that there is no issue with the uterus, and at the same time, on the other hand, there will be the recipient also, the donor also going through the same assessment. And then they both start the treatment more or less at the same time. There will be only a few days of discrepancies, and the assessment normally is done by ultrasound and perhaps by blood tests. So a recipient normally has 2, maybe 3 ultrasound during this process, which can be done at the beginning after 7 to 10 days, and then perhaps after 3 to 4 days to make sure that the endometrium stays stable. At the same time, the donor is instead taking drugs which are slightly more invasive. They're the injection. They're still hormones, but they are aimed at stimulating the growth of the follicle. Every woman has follicles inside the ovary, and the follicle need to grow under the effect of the hormones. So the donor normally is followed in a bit more close way, because there is potentially the risk that the donor may produce too many follicles, too few follicles, because what will be the winning game is to get the appropriate number of eggs, which of the appropriate maturity, so they can be matched with the sperm and produce a competent embryo. So the process of donor lasts approximately 2 weeks. The process of treatment of a donor lasts approximately 2 weeks, and this is the time when the follicle will be growing during the daily injection. So we are talking about at the moment to a synchronous treatment. So a treatment where the recipient will accept the fresh eggs from a patient. And then we'll discuss in a moment why fresh and frozen may be different. So approximately after 2 weeks of daily injection, the donor will have developed follicle of size and maturity which we assume they will contain a competent eggs. At that time, the donor will be invited for an egg collection. So we'll take a final, what we call trigger injection, which has the purpose of making the eggs with the exact amount of genetic material so they can be matched with the sperm. Because the eggs normally has a double amount of genetic material compared to the sperm. So the trigger injection will make the eggs throwing away half of the genetic material so it can be matched with the sperm and create again an embryo with the appropriate amount of genetic material. So this injection normally is given 36 hours before the eggs is extracted, and is extracted through a small surgical procedure when the donor is asleep with an intravenous sedation, with medication given through the vein, but not with a general anesthetic. So the procedure is perfectly comfortable, and the donor is not aware of pain during this procedure. And the eggs are extracted, handed to the laboratory where they are cleaned and they are exposed to the sperm. Very often in a donor cycle, the sperm are injected directly inside the eggs. However, in many other situations, sometimes if the sperm are perfectly normal, we can actually allow a natural selection. So we normally select 30,000 good sperm, and we put together 30,000 sperm with one egg, and we let them to do the work by themselves. So on the other hand, on the other side, the recipient during this time she has been preparing the line of the womb with tablets, and the tablets would have made the endometrium to be of a certain thickness. We normally like to be between 7 and 11. Anything less will trigger some anxiety in the doctor. Anything more as well will trigger some anxiety. Not because there is a problem, just because as a doctors or as a specialist, we like always we don't like outliers or we feel uncomfortable to work with outliers, but not because it doesn't work. So when the eggs are extracted, they will be matched with a sperm, and the recipient will be informed with their partner, or if she's using donor sperm, will be informed of how many eggs are being collected, and then how many of those eggs will be exposed to sperm. It is interesting that sometimes people feel that as the many eggs they may obtain, the better is. But actually, when you look at the studies, there is a magic number, which is 8. Okay, so the magic number indicates that it's been a safe stimulation, hasn't put at risk to the donor, and actually has created a good maturity of the eggs. So getting too many eggs is not necessarily the best option, and of course getting the few is not a good option as well. So at that time, the recipient will be informed that the eggs are there, that's been matched with the sperm, and the next day, the recipient will receive a call, and she will be told how many of the eggs are fertilized. The reason why we do the next day, because normally you look at the eggs 16 hours after they've been exposed to the sperm, because this is the time when the egg start to showing sign of fertilization. So from that point onward, the recipient will then expect a phone call from the laboratory that she will be informed what's going on with her embryos. So let's say that from 8 eggs, an average fertilization will be 70%. So maybe 5 to 6 would have fertilized. And those eggs will start growing. We cannot expect all of them to become beautiful babies. The genetic is important. We know that as a woman age increases, the genetic of the eggs also deteriorate. That's the reason why, unfortunately, miscarriages are more common when you grow older, and abnormal genetic pattern of the babies can be also more important as a woman age increases. So we are expecting to sort of be a selection. As the day goes along, we're expecting to see less and less good quality embryos. Mm-hmm. And the further we can wait for an embryo is day 5. After 5 days, an embryo wants to start implanting somewhere. So there is a mechanism called hatching, where the embryos start coming out of the shell and want to find a place where to host. So that's the reason why we aim at waiting 5 days, but not because waiting 5 days makes the embryos better. It's just giving us the possibility to spot which one are the best embryo. And through a donor cycle, because we're using eggs of a young donor, we would expect the eggs to be genetically quite good. So we would expect always to have one or more than one embryo at the top quality, where one can be used fresh and the other one can be used or can be stored. During this time, the recipient uses another hormones. Well, on the day of a collection, we introduce another hormone which is called progesterone. The progesterone has two effects in a woman uterus. One is to prepare the uterus for the implantation, and also is to prepare the uterus for the bleed. That's the reason why the progesterone will be important at the beginning, before we put the embryos back, and then will be important immediately after to make sure that we support the embryo, because the embryo at the very early stage start communicating with the body of the woman and start telling the woman, please, can you produce progesterone? But in a recipient, because she hasn't ovulated herself, she will not be able to answer the messages. So we give progesterone from outside. Yeah. And we give progesterone until the pregnancy test is due, which is normally 14 days after the egg collection of the donor. Or at the same time the donor had the egg collection, she will be monitored, she will be followed, she will be advised that she may experience some bleeding, very light bleeding, like the hand tail of a period. She may experience some cramping, but it is extremely rare that she will suffer any medical consequences. We normally advise the donor not to try to conceive or to use contraception because she may be very fertile in the few days immediately after the collection, because you may expect some eggs to carry on maturing and being ovulated. So we normally, the donor can monitor medically. They normally go back to work the next day, but they will continue to be monitored by the team, so to make sure that they are physically and emotionally well, because it's also an emotional burden for them. They're giving an amazing gift, and I think they need to be followed from this point of view. So this is the journey, and this is the journey which happens when you're using fresh eggs. If you're using frozen eggs instead, the process of freezing the eggs has already occurred before, because the donor has gone through the process of ovarian stimulation, daily injection for 2 weeks, collection and freezing of the eggs. The reason why the frozen eggs process has taken place and has become now very widely accepted is because it's simpler, it's faster, and you do not require to synchronize the life of the donor with the life of the recipient. So you don't need to synchronize their social life, their personal life, their working life, and the biological aspect of their life. So it's much simpler, and it's made it somehow slightly cheaper as well. However, the pitfalls of those are several. One is that there is still a biological disadvantage in freezing and thawing the eggs. So there is a very important skill that the laboratory need to acquire. So not all the laboratories have the same results. And this is clearly, there is a human factor, very important, which is down to training and to the numbers, like every profession. The more you do, the more you become experienced in something. There is also the effect of the freezing and thawing itself. Even with the new technology, we believe that 90% of the eggs may survive in the freezing and thawing, but still can actually cause a small detriment in the quality of the eggs. Mm-hmm. There's been a very recently a study, and I'm going to speak very briefly about this, where it shows that using fresh eggs can give an advantage in terms of how many babies can be born at the end when you compare to the frozen eggs, but also gives an advantage in terms of health of the baby. There's been a very small differences, but between 25 to 22%. So if you use fresh eggs, the perinatal outcome, so the outcome of the baby at birth, is a bit better compared if the baby was conceived through the frozen eggs. And this, I think, is very important. It was a very interesting study looking at 37,000 women going through the two different pathways. The downside of the fresh eggs is that you get more twins. You got 37% increase in the chance of having a multiple pregnancy, even when you compare for the same number of embryos which have been transferred between the fresh and frozen eggs, and you adjust for all the possible variable, women age and characteristic of the women. So in clinical terms, it's better to use fresh eggs. there is a very marginal advantage in the chance of having an healthy pregnancy and a healthy child at the end. The advantage is very small, but on the other hand, the possibility to use fresh eggs is much less because there are not so many donors at the moment available for how many recipients would like to have a fresh eggs. And I think how we understand a bit more what is the mechanism that create these differences, I believe that eventually using fresh and frozen eggs will be very equivalent at the end. You know, how we improve the handling of the biological material in the lab, the training, I think will make this difference very soon to disappear.
Yeah. That's really, really useful. Thank you. And it's fascinating just to hear you talk about it. And I have so many people come to me going, I don't know whether to go fresh or frozen. And what do you think? And I'm like, well, I'm no expert. I don't know. So yeah, just listening to you talk about that, there are a lot of variables and things to consider when you're going down this route. And it's not just the kind of the outcomes of the studies, it's kind of what works for you and kind of the cost implications and the convenience and on all of those different things as well. And what I really liked as well was when you talked about the optimum number of eggs, because I would have never have guessed it was 8. When we went through our cycle, we got 8 eggs. And I remember thinking, oh, yeah, I was expecting more, having really struggled to get eggs myself. But we had 5 really great quality blastocysts from that. And so I think it's really useful for people to understand that it's not just about getting a huge number, it's that quality that's really, really important. And also really good to know that you're kind of thinking as well about the donor, because as a person who's used a donor, I would hate to think that someone has been overstimulated just to get the most number of eggs from that person at the risk of their health as well. So I think that's really important. It was really nice to hear about what they go through as well, because although we don't know each other, we're in separate places and go through separate experiences, it's very much linked. And yeah, there's a connection there, I think. So yeah, you've answered my second question, which was the difference between fresh and frozen eggs. Another question that I had through was around blood groups, and when matching with a donor, is it important to have the same blood group?
Well, the short answer is no. It's not important because there's no evidence that there is any difference in success rate and in by using eggs or embryos that they may come from a donor or donors which they have different blood groups from the recipient. However, it can be important in some cases. Of course, you know, there are some groups due to religion, cultural, they may not accept the fact that the child may find out about the genetic inheritance. You know, if the couple or the individual decide not to tell the child, you know, we always encourage openness and we encourage you know, recipient to be frank and to be open to their children as soon as possible. And this, I think, will be the future will get better and better from this point of view. But there is still situation where for cultural belief, religious belief, in some patient, this is not accepted. In that case, can be important because, you know, the child may find out later on that his or her blood group is different in a way that could have not been compatible with legal parents. So I think that is what is important to realize. And the third reason why it would be important is if the recipient is rhesus negative. You know, the rhesus negative is we all have the rhesus gene. We carry 2 information about this. I carry 2 information. You carry 2 information. And we may have a rhesus positive or a rhesus negative information. We may have actually both inside our blood cell, you know. So, but the negative one is always, the positive one is always dominant. So if I carry plus and minus, I will always be rhesus positive. If you carry 2 minus, you will be negative. But if I pass my negative and my female partner pass their negative, we'll have a child which is rhesus negative. Yeah. So what is important is that in a woman which is rhesus negative, if the embryo or the child is rhesus positive, she may develop antibodies, which may affect not this particular pregnancy, but the next pregnancy. So when a woman is rhesus negative and she's pregnant, regardless of how she's pregnant, and regardless of what blood group the embryo and the fetus carries, she will always be offered some antibodies injection at 8 weeks and at 16 weeks to ensure that if there is a case that the baby has a blood group different from her, a rhesus group really different from her, she will be protected and the baby will be protected. Mm-hmm. So in this particular case, you don't need to know the blood group of the embryo or the fetus, but it's important that the recipient knows about that blood group, because if she's rhesus negative, she must always be sure that she gets an injection of anti-D during the pregnancy to protect the baby. So we don't need to know the blood group status of the embryos or the fetus or the eggs. We don't need to know, but we need to know what our blood group is, because if you're rhesus negative, we must protect ourselves and the child by making sure that when we are in an antenatal clinic, we get a jab.
Yeah.
So it's actually not important to know the blood type of the donor.
Yeah. And it's really interesting what you said about the sort of cultural reasons and religious reasons that people may still want to keep that information to themselves. And obviously most people know I'm a huge advocate for being open and telling, and I think times have definitely changed. It feels like many more people are going into this being open. I think with the advances of DNA testing, it's not possible for people to kind of keep that quiet forever. But I do know that there are certain situations where people will still wish to do that. Thank you. I'm going to move on to a question that came through, which is actually an issue I had, and it was around the thickness of the uterine lining. And I hear this a lot. I think, I don't know, is it a common issue with people who have gone through premature ovarian insufficiency like myself? But I really struggled to get my lining above that 7mm mark that you were talking about before, and it took a slightly different protocol to get me there. So what can be done if someone's struggling with the thickness of their lining?
I think what is important is to understand why. Okay, is there a problem which is just apparent, or is a problem which is linked to a real pathology which is known or maybe is not known? Because the endometrium is a very dynamic environment. It gets thickened with the ovarian hormones or with the hormones you take as a tablet, and then become compacted with the progesterone and then bleed. And actually you can follow these three phases on an ultrasound with a very clear different pictures. So we as a specialist, we don't have a direct assessment of the endometrium, but we have an indirect assessment, because we see how the endometrium, the measurement and the appearance. You know, we like when we say to the patient, oh, your endometrium is lovely, it's beautiful, it's trilaminar. You know, trilaminar is the expression of a good amount of estrogen priming the endometrium. And then after you start producing progesterone or taking progesterone, the endometrium is compacting, become very cloudy. You cannot see the tree line anymore. But this is a normal development of the endometrium, because now the endometrium is working on accepting the embryo. And then if you don't get pregnant, then it starts to become all cystic again, and it's get filled with blood, and the blood will shed the endometrium out. So this is what we're looking at. And we're looking at the endometrium, and we like in our field to have an endometrium between 7 and 11 millimeter, because studies have shown that below 7 or above 11, the success rate was a bit less. However, the results were probably and very likely biased by the different group of patients, different category of patients. Like, you know, if you have an endometrial pathology where you develop or overdevelop endometrium, which is typical of some women producing a lot of estrogen, you know, women which are overweight, or women which they have polycystic ovarian syndrome, that sometimes is an endometrium above a certain size, is an endometrium which is not great. And the doctor will advise always to perhaps stop the treatment, get a good bleed, and restart again. On the other hand, you mentioned about women which they have going through the perimenopausal period. You know, this is a period where there is not enough estrogen. Not enough estrogen means the endometrium and the uterus has been deprived of the correct amount of estrogen throughout the months. And that is the reason why many women report to have a scanty period during the time. So having less and less. So in those particular cases, what can you do? I normally suggest our patient to get 2 or 3 mock cycle, I call them, where we prime the uterus again with the right amount of estrogen. So get 2 or 3 bleed with the correct amount of estrogen. So the uterus start to having to learn the blood circulation again, because it's all down to blood. The more blood goes to the uterus, the more hormones will be delivered to the endometrium, and the best the endometrium will be. Yeah. So that, I think, the reason why sometimes the endometrium is thinner in those women, around the perimenopausal time or immediately after the menopause. Of course, there are pathologies which are important to spot. Hydrosalpingia, swelling of the tube, we know that is actually causing a damage which is not visible on a scan, for example, but can be seen by a decrease in chance of success when you put a good quality embryos back. We talked earlier on about the possibility of a possible infection. We now learn that the endometrium need a good amount of good quality bacteria, and the growth of bad quality bacteria may actually affect the chance for an endometrium to be receptive and to implant. So what can we do? Sometimes all what we need to do is just to think about the characteristic of the patient. A patient which is obese or got polycystic ovarian syndrome, probably what we need to do is to make sure that the endometrium is shed out very well before you start using the medication to thicken it up. On the other end of the spectrum, you have a patient which has been in the perimenopausal stage or not having a period for a few months. Maybe she needs to have 2-3 cycles to teach again to the endometrium how to grow up. And in between, there will be the patient which they still show some characteristic of the endometrium which is not great, and we need to think about pathology, as we said, swelling of the tube, possible infection, then medication. There are some studies showing that vitamin E, tocopherol, and L-arginine as a supplement can help the development of good quality endometrium. There are some anecdotal evidences, but probably good evidence showing that physical activity, high impact physical activity, which increase the blood flow, blood circulation, can actually increase the quality of the endometrium. And from the doctor's point of view, we normally use sometimes medication which again work on the blood flow. Viagra tablets has been shown to increase the blood flow through the uterus and perhaps helping the endometrium developing. Clexane, all these heparin, this injection used daily under the skin to thin the blood, aspirin, they all have the purpose of increasing the blood flow.
Yeah.
But I think, from the patient point of view, some of the very important questions we get is, should I stop drinking coffee? I think drinking a coffee or a tea a day doesn't make any difference. And of course, if you drink 15 coffee, then, you may create a vasoconstriction. The other things we say to our patient is perhaps to avoid decongestionant during the time of embryo transfer. The decongestionant are like the spray that we use for patients, which once they go for when they have a problem with a blocked nose or something. This is a vasoconstrictor, which sometimes can cause a problem with that.
Okay. Yeah, it's all very individual, isn't it? And I remember in my own case, it was very much trial and error. So for me, I remember it was a lot of trial and error. And eventually what seemed to work was and this was 6-7 years ago, but I was told to take my estrogen vaginally as well as orally.
Yeah.
So that it's closer to the site of absorption, and that seemed to work. But I know it's one of those things you've just got to work with your consultant, haven't you? And follow their advice.
The consultant as well will not know your uterus. There is not a special magic formula which we can use to say which estrogen is better for you. So it's sometimes try, and you're absolutely correct. You need to work together. I always like to think that this is a journey not just for the patient and the partner, but also patient, partner, and the specialists which are treating you. You work as a team. You need to trust each other, and you will see that sometimes the doctor or the specialist struggle to understand what is the best recipe for you, and you need to try and learn from experiences. Maybe you say, okay, this drug is not good for you. We may adapt differently. Estrogen is given by gel, by patches, by tablets, vaginally. So there are so many ways to administer the hormones. And this is similarly, a woman goes through the roller coaster of symptoms of hormone in a different stage in their life, when they're young, when they're using the contraceptive pill, some of them, they like the tablets, some of them, they like the patches, some of them, they prefer the vaginal ring. Similarly, when you reach the perimenopausal stages, the hormone replacement is given in different way because basically to try to address the individual need of the patient, because the individual need is probably linked to the skin absorbing less, or some mucosa being better than other in delivering the drugs. So there are different options, and again, you assess those options based on patient symptoms and the quality of the endometrium, which is assessed by ultrasound only. That is.
Yeah, I think it is. The whole thing is just so individual, isn't it? There isn't a one size fits all when it comes to these processes. No. My next question is around, and this is something I get asked a lot as well. At what point or what circumstance would you suggest further testing, such as immune testing, NK cells, things like that? Because quite often when people come to this, they may have been through several failed rounds with their own eggs, and they want to throw everything in the kitchen sink at it so that it works first time. But is that something you would recommend, or in what circumstances would you recommend that?
It's a very controversial topic, very, very controversial. And again, I think there is a lack of clarity in what tests are available, what can be useful, but also there's a lack of clarity on how select the patients which may benefit from tests. Because patients which they have perfectly fine, all the investigation, the medical general investigation are normal, and they fail some attempt despite being told that everything looks normal, most likely do not have any immunological problem. They've just been unlucky, because unfortunately it's a number game. We need to remember that all the studies have shown that eventually the chance are increasing as the number of attempt increases. Okay, so there is not a situation that the chance stop increasing despite increasing the number of chances, unless there has been a medical problem which has been overlooked or not spotted. There are immunological issues, conditions which can affect the chance of falling pregnant. And for example, the most common are immunological condition affecting the blood or the thyroid. We very often assess a woman for thyroid dysfunction. There is always a controversy how good should be the TSH, which is the hormone regulating the thyroid. Should it be above or below 2? And this again, there are two group of thought. There is a European and American group which is more aggressive and say, the TSH should be kept below 2 because we think that it's a chance for a woman to get pregnant and not to miscarriage is better. The British, the Anglo-Saxon is more conservative, and they like to think, there's no evidence on this, so why we need to start giving thyroxine, thyroid hormone, to a patient trying for a baby. Similar conditions such as lupus or rheumatoid arthritis, we know that those patients, those women may suffer more complication or may find more difficult to get pregnant. And there are medication for this. There are specialists. If the patient is managed by the appropriate specialist, there will be medication which can counteract the negative effect of the immune system or the chance of conception. There is then the area of reproductive immunology, which is very unknown at this time. We talk about natural killer cell. Natural killer cell, they have unfortunately a very bad name. So they're natural killer, but they actually have those which have been protecting us. At the moment, they're protecting us from COVID, okay? And they are white blood cell dislocated in different areas of the body and keeping a memory of what dangerous pathogens is coming in. And the theories say that, if they become a bit crazy, they may start overreacting or reacting against your own body or against an embryo, which is supposed to be something foreign and just arrived from outside and the body doesn't recognize. However, there are no evidences that those cells actually make any damage to the embryos. And what is worse is that there is no logical way to assess it, because, if we start checking the blood test in the arm, doesn't represent the population natural killer cell inside the uterus. So, I remember there's a professor, one of the scientists which discovered the role of natural killer cell in general in the body is called Professor Moffat, and she worked in Cambridge. And I remember years ago, I was at a lecture where she was talking, and she was saying, look, testing the natural killer cell in the blood and try to assume what is the condition in the uterus. It's like counting how many yellow cabs in the M25 if you want to know how many black cabs are in Trafalgar Square. You're talking about two complete different things.
Yeah.
So I think, we are abusing these those tests, and I think, even the possible measure and therapy which has been suggested have been unproven, and some of them quite detrimental. There's been cases of deep vein thrombosis, for example, of using immunoglobulin, or using prednisolone, especially if you have a condition such as diabetes. Using steroids may increase your chance of getting diabetes, increase your chance of getting an infection. So I think I will always discuss with your specialist the benefit, the merit, and the possible side effect. And of course, when you reach a stage where you start considering those tests, is because many other things have failed. So you need to think about, as a specialist, you need to think about how to reassure the patient and try to work together on what would be the best. But there's no evidence at the moment the natural killer cell will be of any benefit during the investigation process and in the treatment.
Yeah. And that's really, really useful, because I think sometimes there is a lot more information available now, which is great in some ways, but in other ways it can throw up a lot of questions and you think, oh, should I be considering this? But my final question is about, and you've mentioned a few times about it being a numbers game. And I think that's one of the things we can often forget, particularly when you kind of say, right, I'm going to stop with my own eggs and move towards donor eggs. And the percentage chances for me were tenfold more. And for people who don't have success on the first time or the second time or even the third time, what questions should they be asking? And what would you be kind of suggesting to them if they've moved towards donor eggs? Talk to me a little bit more about the numbers game and what sort of things we need to think about there.
Yeah, I mean, the numbers game is, the concept is simple. There are two main variables, which are the positive variable in this algorithm to win at the end. One is the age of the eggs, and one is the number of the eggs. Okay, the age of the eggs is something we cannot do anything about. Okay, because once we have a donor of that age, there's not really much we can do. Okay, we can try to get a donor younger, but it may take another year. So the age of the eggs is directly linked to the genetic of the eggs. We know that at the age of 30, approximately perhaps 1 in 2 eggs are genetically normal. The same woman, when she will be 40, she will have 1 egg every 10 genetically normal. So there is a sort of a process in nature which makes women losing good eggs first and keeping the back eggs later on. So that is immediately showing us that even at the age of 30, a young donor will not have every egg genetically normal. We don't have drugs which can make the eggs better or only the good eggs coming out. We only have drugs which make eggs coming out. That's the reason why having a good number is good, but not too many, because too many means we're going to get the eggs which are left out by the ovary to die, and we try to get them out as well, which will be no use to us. So that is where the numbers game comes from. So you're going to have a set number of eggs, a certain number of embryos. However, even in the best circumstances, you will not have more than 50-60% of those eggs being genetically normal. And this is where we need to understand that, even having a good number of embryos at the end of good quality, that doesn't mean they will translate in all of them becoming a baby. So if you want to be realistic, and we should be realistic, we should be honest to patients, the best chance of success when you use when you go for treatment with donor eggs, I would quote no more than 55% chance of success by using those eggs. Then there could be the situation where from this lot of eggs, you may have 3 beautiful normal embryos, which will translate in 3 beautiful child. However, it's impossible to think you're going to have 100% of those embryos. Like, you mentioned about the case, which is close to you, you got 3 beautiful embryos, which became 3 beautiful children. But, the remaining eggs probably were not good. And those that became an embryo, they became an embryo because there was a good genetic material, but also good handling by the lab. I think, the laboratory did a very good job. The doctor did a good job in preparing you and preparing these eggs and the sperm and creating the embryo and selecting those which were only good for you, and avoiding the rest.
Mm-hmm.
So that is where really another problem is, sometimes if you have too many eggs and too many embryos at the end, it sometimes is detrimental because the patient end up trying several times with the same bunch of eggs and embryos that coming from the same treatment cycle, and failing 3 attempts, all from embryo coming from the same donor is not similar, is not the same as failing 3 attempts with embryo coming from 3 different donors. Mm-hmm. The latter would be much more worrying to me, worrying that maybe I'm missing something. And this is where I think, the doctors and the specialists and the patient need to every time do a step back and reappraise the situation. Let's say, okay, we failed this treatment today. This is your first treatment. Why did we fail? Do we think it's only the role of chance, or is it anything else? And every time reappraise the situation, it does when you look at the same aspect and the same problem, but at different time, you may find something different. You may look at from a different angle. So I think it's important always to reappraise the situation and this conversation, this sort of exchange always with your clinic. I think the way the clinic approach this, I think is important because it may reassure or put anxiety on the patients. The role of chance is down to age and the number, as we said. From a donor using fresh eggs, which provide you, for example, 5 good quality blastocysts at the end of the journey, and the donor was 30, yes, you can expect to have had 1 child, at least in 70% of the cases, to have had 2 child in much less percentage, to have 3, I think you hit quite a jackpot. But chances play an important role. That's the reason why, if we were, unfortunately, fertility in some countries is not seen as a social problem, and that's the reason why there's not enough investment. We still hear sometime on the media that we should cut down the fertility funding. Actually, if you think the cost of an IVF baby or a fertility baby to the taxpayer is about £12,000, and think about this baby, how much will contribute in pension scheme in the future. So I think the government should actually invest more and allow more cycle fertility treatment to patients, including the donor treatment, to allow them basically to conceive, because it's a number game, and the number game unfortunately is affected by the financial availability of the couple.
Yeah, absolutely. I completely agree with that. And I think what you talked about, where managing expectations, being realistic, is important as well. And I remember first going into my first cycle thinking IVF equals a baby, and it doesn't. And also then donor egg cycles will give you a better chance, but it still doesn't always.
It doesn't always translate to that.
Yeah. So thank you so much for talking to me. And there may be more questions that come up in the future that we can chat about again. But I think it's just given people a real good understanding of what to consider and kind of the medical side of things.
Thank you, Becky. It's been a pleasure, really, and anytime.
Thank you very
much. Congratulations. You're doing a great job, and I think we should be supporting you more and more.
Thank you. It's great working with you guys.